I really started to see how I could have an impact and how I could be the voice for not only the frontline staff, but also, the patients. And so it really ended up filling my cup, part of my career that I never really thought that I needed to have filled.
Hello, everyone, and thank you for joining us for another episode of our podcast. Today, I'm speaking with Deana Sievert, Chief Nursing Officer at Ohio State. Deana is this rare blend of an academic and a clinical expert. On the academic side, she holds a Doctor of Nursing practice with a specialization in nurse executive leadership, a Master of Science in Nursing and Adult Health Nursing, and a PhD in Nursing Leadership. And she's done all of that while also being dedicated to hospital and healthcare operations, with a particular focus on acute care, electronic medical record systems, inpatient care, and critical care nursing. Deana, that is a lot. Wow, I can't wait to learn more about it. Thank you for chatting with me today. Before we dive into this episode, could you tell us a bit more about yourself?
Yeah, I've been a nurse now for just over about 32 years. The majority of my time has been spent at the bedside as an ICU critical care nurse. I did mostly adult healthcare at that time. And then leadership was not something that I ever really wanted to move into. People would say, "Oh, Deana, are you interested in going into nursing leadership?" And I would say, "That's like the worst job ever." Absolutely not. I would never want to do that. And so eventually, I actually kind of got, I actually was bullied a little bit to go into my nursing leadership job by my team that I worked with. And, I got into it and I really started to see how I could have an impact and how I could be the voice for not only the frontline staff, but also, the patients. And so it really ended up filling my cup, part of my career that I never really thought that I needed to have filled. And so once I kind of started down in the leadership track, pretty quickly just moved up the ranks and ended up as a chief nurse executive. And I've been doing this now for, probably close to 15 years now as chief nurse executive. So, and still enjoying every moment, really. So
I can tell. Well, I'm glad to hear that. And yeah, it's not an uncommon theme I've heard from others that started with a clinical orientation and really didn't want to leave clinical practice and take on leadership. And, either were so frustrated with the environment they were in that they felt they had to do more, or otherwise kind of stumbled into it, maybe coerced into it in your case, and then ultimately found a higher purpose there. So that's very interesting. Maybe if we kind of step back, though, what led you into nursing? How did you get into healthcare to start with?
Actually, I didn't start down the route of nursing. I had always thought that I was going to be like a pediatrician is really where I thought I would end up, was being a pediatrician. And then, as I kind of got into my undergrad studies, it just ended up not being what I thought it was going to be. And so I had a very close friend of mine who she was older and she was like, you should try nursing. You've kind of got that grit to you. You've got, that empathetic approach. You're really good at communicating. Have you ever thought about nursing? And I was like, no, I've never really thought about nursing. And I ended up going and talking with my college advisor. And after talking with them and, just learning a little bit more about nursing, I really kind of thought, gosh, this sounds really great. And so I ended up making that switch my sophomore year of college and ended up then getting into the nursing program, and it went so well. And that was really how I ended up getting into that approach. I always had that draw. I think it was probably just that desire to want to be a help to people. I don't think that there was anything other, my whole life growing up, I had always been told, you should be a teacher, you should be, a physician, you should do something like that. And so I think ever since I was a little kid, I heard that so much that I just kind of grew up that way. And I really didn't want to go into teaching. And so that's really how I ended up moving into the healthcare space.
And so you've got this career as a clinical nurse, you're in the ICU, you're dealing with adult patients. but you didn't stop your education path there. I just rattled off a few of your degrees. So you're obviously continuing to pursue higher learning. What was the interest there? And how do you balance that? Like kind of academic, there's something very academic about it. And like a nurse, if anything, like is the personification of like hands-on, sleeves rolled up, sticking needles, hands-on patient. Like how do you balance those two worlds? And what drew you into the academic side?
So when I was at the bedside working as a staff nurse, I loved the teaching part of it. I loved being the preceptor. I loved being, a clinical expert where whether it was a med student that was, coming in for their rotation, working with the physician residents, any of that, I just loved being able to talk with them and to kind of educate them and just help them to see exactly what was happening with all of our patients. And so I've always had that draw towards really, teaching and learning and all of that. And so that's initially what prompted me to go back to get my master's degree as a clinical nurse specialist, because a clinical nurse specialist, really the foundation of a lot of the work that they do is education, both with patients and with staff. And so it was a really good blend. But then, as I said, my career kind of took a little bit of a left turn to head into leadership. And then once I got into nursing leadership, I realized that I had a gap. I didn't have like the business acumen and I didn't have the systems thinking because I really only lived in critical care. And so going back then for that doctorate of nursing practice really made a lot of sense. I picked up a lot of that obviously just through on-the-job training and whatnot, but to go back and get that formalized training to really solidify everything and pull it all together, that was really what drove me to kind of go back for that degree.
Mm-hmm. Very interesting. So it kind of helped you to increase your aperture, take a broader lens. You were already in the job, but you're creating now more of an academic backbone to maybe develop that systems thinking. That's kind of a triple threaded almost career pathway, right? Clinically, leadership pathway, and then an academic pathway. We'll come back to education because that's a topic that I often think about in the context of transformation, because it does feel like in many ways we're still teaching the same way that we were taught, not recognizing maybe that the new class of practitioners, whether nurses or physicians or other roles in the healthcare system, have a very different learning orientation, a very different approach to technology. So I do want to unpack that a little later, but maybe just in terms of continuing down the career pathway. So now, how long have you been at Ohio State?
It's almost 2 years now.
Okay. You came, I think, from a community hospital, right, in Toledo? Is that
right? Yes, a very large, they were still an academic medical center where we hosted a lot of residents and attendings from the academic side. But it was a very large community hospital and a large system, 11 hospitals at the time when I was there. So.
Mm-hmm. And so moving to Wexner, which is this, world-renowned tertiary care center, academic medical center. What's that like? Is it very different from more like the community trenches? I know you were at a very large hospital in Toledo, but nonetheless, maybe what's the kind of what are the differences you've seen there in your progression?
First of all, you have to be a Buckeye, right? You have to favor the Ohio State Buckeyes. There's no way around that, and you have to be a football fan no matter what. And so
I think that's true for all of Ohio. Like in Toledo, you have to support the local team as well, don't you?
Well, it gets a little divided up there because we're only an hour away from that school up north. And so in the Toledo area. So you got to be careful up there. But it's been a lot of fun coming down here. I think that the difference, if I had to put into words what the differences are between where I've been in my career and here at Ohio State, the complexity, not only in regards to the level of patients that we care for, right? The acuity of the patients that we get, they are truly, truly so very, very sick. I remember I used to say that at a lot of the other hospitals that I worked at, which was, we take some of the sickest of the sickest. And, and as I've kind of progressed in my career, it's really added a whole different level of perspective to that. So, I think how I would describe it in one word is just the complexity of what we do here at Ohio State. And that's not only in regards to the patient care, but then also the community work that we do, the innovation work that we do, the research work that we do. All of those things are very complex as we're moving along and really trying to improve healthcare overall for all of our patients.
I could see how that would be a big challenge. I feel in many ways the role of leadership is to remove complexity and simplify things and set forward a clear course for the people that we work with or that work for us. And so I can imagine in such a multifaceted organization, research arm, community arm, acute care, tertiary care,
education,
innovation, education, of course, very, very big. One of the largest, I think, medical schools in the country. That must be a non-trivial challenge. You mentioned innovation. That's a big theme for this season of our podcast. And I always like to think of innovation as like an applied science that's there to solve challenges. And so we talked on one challenge that you see from where you sit, which is complexity. What other challenges do you see kind of at large in healthcare, maybe in the US or specifically in the world that you're in?
Right now, what I would say is that one of the biggest challenges, and although it's settling down a little bit from where it was even a year or two ago, the workforce issues that we are all having, right, it has really been just so severe. Being in healthcare now for 30 some years, I've lived through a couple of the nursing shortages now. And I will just say this last one was so different, right? And it wasn't, I think the reason why it was so different, obviously with the pandemic had a huge part of that, but we didn't see the bounce back, right? And even now today, when you look at our nursing schools or even, medical schools, all of that, you're hearing all of these stories about enrollment being down. And that's very different from how it has been historically, where we always knew, hey, this is temporary. We've got more recruits coming out, and and that's different now. And so where before maybe they were more of a shorter-lived problem around workforce, now I think this is going to end up being our new reality. And speaking with my colleagues around the country, they're feeling that too. They're feeling like this may be our new reality, and I think that that's why, particularly over the last couple of years, we've all had to lean into different ways of thinking, innovations, technology. How are we beginning to incorporate all of those things into our daily workflows? And I think in some ways, right, the pandemic, although there were certainly a lot of negatives about it, the fact that it's forcing us and pushing us to move into more technology, move into more innovative spaces, I think is really exciting.
And so, I'm the CEO of a technology company. What advice would you have to us as a technology industry? Like, how can we help to address this challenge, recognizing that part of it is maybe making the lives of those in the profession a little easier so that we can get more new recruits, so they can envision themselves being satisfied in those roles, which I think is part of the post-pandemic challenge. And part of it is maybe productivity. Like you said, there's kind of less people doing the job. Could we have better processes, better tools, better automation to get the job done? What would you like us, what is the call to action for us as technologists to help you succeed in overcoming these challenges?
Some of the greatest technology, companies and innovators that I've worked with have really kind of come into the healthcare space, into that clinical space, and really just see the work that we do, right? I think sometimes as clinical people, we get so narrow-minded, right? Because this is how we do it, and this is how we've always done it, and this is the way we're always going to do it. And I think that that's very short-sighted of us as clinicians. I relish bringing in vendors and whatnot to come into that clinical space and show them, here's what our problems are. Here's what we're struggling with. Can you help us with this? And, and I think when you put that clinical mind together with that technology mind, that innovation just automatically happens, because working together, I think we can really come up with some really amazing and great things. And I think certainly, listening to that clinical voice is imperative, but then I think also the clinicians have to be willing to let down their guard and also listen to the technology voice. So I think my biggest piece of advice would just simply be, jump in there with the clinical team and let's innovate together, because I think together we can solve way more problems. And that's been my experience.
I can share a bit of an epiphany I had around that, which is, not only really diving in and trying to understand the workflow, but making sure that it's really tailored to different types of clinicians. I think I told you I was a long time, I led a PACS business, so software systems for radiologists and cardiologists to interpret. And then I was a CEO of an AI company that did like automated interpretation of medical images. And so always kind of the clinician was the doctor, was at the center of the experience. And when I moved into Claris 2 years ago, really the promise of handheld ultrasound or point of care ultrasound is opening up the adoption of this amazing modality to in new use cases and to new users that maybe didn't have access to this type of technology before. And that's really forced us, I think, by design to really understand the workflow of, let's say, a nurse different from the way that a doctor works. And that's been so invaluable, really, to kind of meet them where they are. Like you said, try to infuse our own ideas on innovation to push the limit, but also make sure we really understand what's the problem that we're serving. And so just to kind of expand on your idea, maybe I can share my experience to other technologists that are listening to this podcast, which is to really tailor that clinical understanding to different sets of users. And we learned a lot from nurses, where I think so many software companies in medical technology or health tech are really keeping the physician at the center of the experience, which of course is important, but they're far from the only stakeholder. And maybe as we talk about labor shortages and, kind of workflow bottlenecks, there's going to be other practitioners, other allied service providers that maybe open the door for overcoming some of those challenges. So that's just my takeaway on kind of putting the nurse at the center for some of our use cases and learning so much from what they do and how it differs from how a doctor in a similar ward might behave.
I think that's a really great perspective. And thank you for sharing that, because you're so right. And especially, as we all know that hospital margins keep getting more and more compressed. And so, if you have a technology that can be used over, by multiple disciplines, what a game changer, right? I mean, and so I think that your comment there is just really interesting and really profound, because I think so many times that's one of the barriers of bringing technology in is that it's really isolated to only this clinical team, and to have that ability to, like an ultrasound, to have it used by physicians, but then also have that same technology be used by nurses. I mean, that's just a game changer on our side for being able to really control that work and really be able to get the best case situation out of that. So very good. That's awesome.
Yeah, maybe to expand on an idea that you raised earlier around education, and clearly you've got a lot of knowledge in this, a lot of stake at this. You've been at this for a very long time. Part of, I think, like just again, in the narrow world of ultrasound where I live, I'd say the biggest potential to unlock the addressable market is to overcome the education barrier, because for many of the clinical use cases and practitioners that we talk with, they say, oh, I'm an expert in this field and I really think that imaging would help, but I don't know how to use ultrasound, or I don't know what it looks like under grayscale. I know what the anatomy looks like. Of course, there is a big push across many health systems to integrate more education, both in residency programs for doctors, but also for nurses and nurse practitioners and physician assistants. But we're also just trying to think about other ways to educate, more in line with the fact that, there are generational gaps, and the way that my teenage children learn how to use a new technology differs from how I did learn how to use it. And so maybe what advice could you give us on how to think differently about educating and about educating different roles, back to your point around kind of, serving multiple stakeholders in the healthcare continuum?
Yeah, boy, that's a conversation I think I have inside these four walls here at Ohio State at least every week, if not more frequently. And, and we're seeing that with the, I think we're getting to a point though that we have more clinical staff who are very technology, savvy, who are very tech savvy, where comparatively over the last decade or so, that hasn't always been the case. I think we still have a little bit of a divide, but, I'm finding, at least in the nursing teams here at Ohio State, that having a multimodal approach, we still do that. But honestly, so many of our clinical teams are leaning into the technology and excited about that. And so, I guess what I would say is that right now I see that forefront changing very much, right? I see that whole environment changing quite a bit, because right now we are having the transitions and the generations, with the baby boomers leaving. A lot of them have gone, and I think the last few that are here are probably close, Gen Xers, which I'd be one of those, and so I think, we've done a good job of adapting. But, when you look at the millennials and the Gen Zs, I mean, they just eat up the technology front. And so, I think things like virtual reality training have a huge place in the clinical setting. I think we've got a lot of potential around that. And, and I think that that's a great way to really, when you have a technology like, the point of care ultrasound, I think that a couple of things, pairing that with VR training, wow, that really gets the teams excited, where they can touch and feel the point of care ultrasound device, but then put on the VR headsets and now actually kind of get to practice using it in more of a real life situation, with scenarios and whatnot. And so I think we've got a lot of opportunity there. And, it's really interesting. I can only speak for nursing, obviously, on this one, but, so many of our colleges of nursing now around the country have nurse innovators on their faculty. I know we do here at Ohio State. We've got, our College of Nursing has an entire innovations leg to it. And, they're really trying to change the way they're training their nursing students. Mm-hmm. And then over here on the hospital side, we're leaning into that to really try to continue that work and continue that use of technology and, different innovative training methodologies. We're really trying to embed that into how we onboard nurses, and then how do we maintain their competencies down the road. I think there's just so much there to unpack, but it's so exciting and really huge opportunities there.
I've never heard of that role before, nurse innovator. I love it. And I think every academic medical center needs to have that position. I think, virtual reality certainly is such an important way to get that hands-on experience without actually needing to be in a clinical environment with a patient. Another thing we've been investing in, again, in our narrow world of imaging, but I think it's applicable in many other medical technology use cases, is using artificial intelligence real time. A lot of AI in imaging was initially applied to like a post-processing, to kind of ultimately remove the need for a radiologist by having the machine auto-interpret the images. And I think that could have legs over time. It's not trivial for a variety of reasons, and also medical legal liability. But in ultrasound, the key focus of AI is actually image acquisition to help you in real time know either how to position the probe, rotate left, rotate right, gamify it. Like you said, these Gen Y and millennials and Gen Zs, they are embedded in technology from the cradle, right? And so for them, it's very intuitive when AI shows you, rotate this way. Now you've got that perfect 4-chamber apical view of the heart. And another thing we invest a lot in is auto segmentation, so that we can have the AI auto detect the anatomy and then adjust all the presets to get the best possible image. Again, overcoming the need to learn all the buttonology that a sonographer might otherwise use to really get that, beautiful ultrasound image, which is not easy. So excited to, to learn more about how these nurse innovators can help also inform us on what works well, because I really think that in this technology space, at least, and many others, really overcoming the need for kind of the straight directive medical education classroom based is going to be the key to allowing it to proliferate.
I couldn't agree more with you there. And I think the AI space is so interesting, and, I think it's going to change. Like, I don't even think we can fathom sitting here today, exactly how much the AI technology is going to change our day-to-day work, right? And, we'd like to say, particularly, and I'm sure you understand this in imaging and ultrasound, right? We think that everybody's insides look like they do in the textbooks, but as we all know, that's just not the case. And, and I think that that's the truth for so many of the clinical team members, not just, the physician when they're doing some of the big procedures. And that, I think that's where you see AI really allowing a much safer patient care experience for our patients, right? Because where maybe we didn't have that insight into that specific patient's anatomy or whatnot, now we will have. And that's going to be a game changer when it comes to safety events, outcomes for our patients. I really am excited for what AI has to offer for us.
Well, already I've picked up a lot of great tips for you. Just doing a quick recap, you talked to us about, as technologists, the need to really understand and observe the workflow. What's the problem we're looking to solve, on finding that collaborative spirit and kind of the yin and the yang of technology and the clinical space working together to solve problems. We talked about how to unlock the potential of other practitioners across the care continuum, not to make sure we're not being siloed in one use case or one pattern of behavior, recognizing there's many hands that touch the patient in their journey. And then third, just on the use of technology in education, really embrace the fact that the younger generation of clinicians coming into the workforce can learn differently. And then, kind of finding those innovators to work with that can help catalyze maybe new ways to embrace education styles and drive these solutions home. That's great. Maybe if we take even a step back, I'm always keen on the role of understanding really the role of nursing and where it's going, because we talked about this before we went on camera, that, historically kind of healthcare was really driven towards hospital-based practice with a physician as kind of the quarterback, to use a football analogy, like coordinating the care. And I think that's changing. And so kind of in your 30 plus years of transformation, not only looking back, but also looking ahead, where do you see this going? What role can nursing play, and kind of what can we do to help support and kind of pour rocket fuel on that fire to help that transformation continue?
Technology has already had a significant impact on nursing. You go back to even 10 years ago, 20 years ago, the number one place to get a job back then was in the hospital setting, right? That's where probably 95% of nurses started their career, because that was the coveted job, was to be, at that bedside, at that stretcher side. And what we're seeing now is, because technology has really opened up so many different avenues for nursing, right? I mean, who would have ever thought 25 years ago that a nurse could take care of patients from working at home, right? I mean, but yet they're doing that, we're with the telehealth platforms that we have. And so, you think about not only the fact that the landscape of nursing is completely changing, where it used to all be heavily focused on the hospitals. That's just simply not true. I mean, now we've got all of these ambulatory centers where, patients are coming in for big procedures and there for less than a day. And, and that's changing the look of nursing. You've got the fact that now there are so many telehealth platforms where nursing can camera in and actually get more information from that patient than we ever have, because they can see the home. They can see, what food do you have in your refrigerator? Let's take a look at, let's do your meal planning for the day. All of those things are opening up so many different aspects into nursing and patients' lives. And I think that's just going to continue to grow and develop. And as a chief nursing officer of a hospital, I have to be honest, it scares me, right? Because I'm thinking, who's ever going to work in the hospital setting anymore? Because everybody's, definitely loves being able to have that flexibility from home. And unfortunately, hospitals are and will always be 24/7 operations. So there's that part of it that is very scary for me. But the innovator inside of me and all of that, it's really exciting. I mean, this hospital at home, where a lot of us are doing hospital care at home for acutely ill patients, and we're having better outcomes with that, right? I mean, patients, they want to be able to get better. They feel better if they're laying in their bed at home. They feel better if their family is able to stay with them during that whole time. And there's so many different opportunities there that's just really exciting. And it's going to definitely change the entire landscape for nursing.
Is that supported also, though, by the finances, right? You're a healthcare leader. You know that everything ultimately has to be anchored by dollars and cents. In what is still predominantly a fee-for-service environment, can we have the right stimulus to get more care in these alternate care settings? I mean, I know generally it's expensive to hospitalize someone, but for example, to deliver ambulatory care for much more complex procedures or even in-home care, can we make the finances work?
I think we can, but we're going to need some help, right? We're going to need some help from our third-party payers, from our governmental payers, who hopefully can get out of our own ways so that they can see what the future is. I mean, I think that certainly the entire pay for performance model, that pushes us towards some different models, right? Because if the patient's in the hospital and, and we see this so much in like our older patients where they come into the hospital completely cognitively intact, but then they get into the hospital and they're not in their normal surroundings. So they get delirium or they get, disoriented, they fall and they break their hip in the hospital setting. The likelihood is that it would have been cheaper to take care of that patient at home because they probably wouldn't have got delirium. They probably wouldn't have been disoriented and they wouldn't have.
But only if you own the outcome and the total payment, right? That's, I guess, the issue.
Right.
Like if
That's
you're
the issue.
so procedure and service oriented, then the fact that they had other complications, it's kind of not on you. So that, I guess that's the challenge. You said you have to get the payers on side as well.
That's exactly right. We've got to get away from the transactional types of interactions to more of the, what's the episode and how are we actually controlling costs through that episode of care and improving the outcomes for the patient. And, even though hospital at home is relatively new across the country, and by new, it's probably been around for maybe a decade or maybe a little bit more. But, as what we're finding is that the patients really value that and they're having really good outcomes when they are at home. And so it does bring in that whole challenge. Now, certainly, I don't know that we'll ever get to taking care of a critically ill patient or a patient, certain cases will always need hospital care. But, I do think that some of our lower acuity patients that are sitting in a hospital today, there's a whole platform of what can we do, to take care of a patient. So at home, I don't know. I mean, could we ever do, different types of ultrasounds and other things at home? I'm sure there's a way we can make those things happen eventually.
That has us very excited. I just came back from Japan in the fall, and a big part of the point of care applications in Japan is for home care. They have an aging population and some of them are immobile, and they have a dearth of practitioners, like labor shortage, similar to what you're experiencing, but on a much older base of patients. And so they're doing, quite complex procedures and certainly diagnostic or even simple interventions guided by ultrasound at home. And that's, I think, part of the promise of this modality, right, is that you can actually take it and kind of intermediates that legacy referral pattern that someone had to come into the hospital and then you move them on their bed to radiology, they get imaged, then they come back, the results come back. Like you're really shortening those workflow cycle times and doing it in a care environment that is the most convenient for the patient and in many ways also maybe the most cost effective for the provider.
Yeah, absolutely. It's exciting. I'm excited for the future. So
I can see that. No, your enthusiasm is really infectious, Deana. I really appreciate all of your ideas and remarks and great advice. We're just about to come to a close, but if our listeners want to learn more about you or to follow you on social media or learn more about what you're doing, where should they go? Where can they find out more?
I try not to do social media. I got to be honest with you. I am on LinkedIn. So you can always find me on LinkedIn and it's, just Deana Sievert out there. So that would probably be the best place to get a hold of me. But otherwise, we're always up for connections. Feel free to definitely just, if you get into the Ohio State network at all here, you can find me. And so happy to connect with anybody and would like that very much. Always looking for new people to network with. But
awesome, Deana. Thank you so much. I really enjoyed our time together. Very much appreciated. And to all of our listeners, thank you for joining us for another episode of our podcast. That's a wrap. Bye-bye.